Webinar from the Connecticut Health Policy Project. I'm Ellen Andrews, Executive Director of the project, and we're fortunate today to have Scott Cleary with us. He's the Program Director of eHealth Connecticut and has been since its beginning in 2006. eHealth Connecticut is a nonprofit organization working to expand adoption of electronic health records and information exchange in Connecticut. He'll be talking about eHealth's pilot health information exchange that is operated with, right now, 3 hospitals and 1 federally qualified health center with 20 different providers. Community providers will be joining very soon. A little housekeeping about the webinar. If you're listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. We'll be keeping everyone on mute until Scott is done talking, and then we'll have some time for questions. To ask a question, you can raise your hand by pressing the button, or you can type your questions into the question pane text box on your screen at any point in the webinar. And a video of this webinar will be posted online. So Scott, if you want to get started.
All right, Ellen. Well, thank you very much, and hello, everyone. And thanks, Ellen, for setting up this this webinar. I'm thrilled to do this at any time for anyone who wants to share this information. So just keep that in mind. I think Ellen shared with me some of the folks who are on the phone, and I think we have a nice kind of cross-section of some state agencies and some hospital people and maybe even a practicing provider or two. So this will be a nice little session. And Ellen is going to drive, right, Ellen? So all I have to do is say next, and then we wait a few seconds while the new screen gets propagated through the internet. There we go. And by the way, this presentation is available online at the ehealthconnecticut.org website. If you click on the Health Information Exchange button, you'll be able to find education or training resources, and you can actually see this presentation there with a little bit of voiceover PowerPoint. Oops, Ellen, are you going too fast? Can you go back to two, please? Okay. So we're going to get into how this pilot program actually works, and I'm thrilled to say that we are live in production with real providers, real patients, real data. So this has been a long time in coming. We've basically been at this project for a couple of years, and as you'll learn, the technology is probably the easiest part. The more difficult things are issues like privacy policy, consent process, developing a single contract data sharing agreement among all of the providers, and I'll get into some of those things as we go, but it certainly is much more than just a technology science project, if you will. So we'll talk about how it works, get into the benefits of health information exchange, and then see what questions you might have. And I'll probably go for 20 or 25 minutes, and then we'll have plenty of time to respond to any questions you might have. Okay, here's our outline. Ooh, Alan, can you, I wonder, maybe you on automatic play or something. So here we are, objectives, talk about the relationship between eHealth Connecticut and DSS, what is health information exchange, as I mentioned, a little bit of benefits, risks, how it works in a little bit of detail, and then some of those tough issues like patient consent, security, and so on. Okay, next please. So we've been engaged, eHealth Connecticut has, with DSS, our client. DSS has directed this project, and we've had a wonderful relationship with DSS going back a couple of years now. And this project, by the way, is funded by CMS, the Centers for Medicare and Medicaid Services, the federal agency. So we've been able to basically take that federal investment and apply it, and and get some real results here in Connecticut. So back one, please, Ellen. Okay, I guess forward. All right, as Ellen mentioned, we've got the objective of the pilot project is to get at least 3 hospitals and 2 federally qualified community health centers up and running. And I'm thrilled to report that we do have 3 hospitals that are live, and those are St. Francis Hospital and Hartford Hospital here in Hartford. And that's That's actually very interesting and important because, you know, as much as they collaborate around patient care here in the city, they're competitors. So to see that two competing hospitals have both seen the value for their patients and for their providers of plugging into the HIE, I think that's a very important point. The other hospital is Lawrence and Memorial Hospital down in New London, and the two federally qualified health centers are Staywell, which operates in Waterbury, and also Community Health Center, Inc., which has actually quite a few locations around the state, but big operations in Middletown and New Britain and so on. And they also operate a clinic in New London. So it's important that we get CHC up and running so that they can basically share information with Lawrence and Memorial Hospital. So to the extent that those patients go back and forth between primary care at CHC and acute care at L&M, the Health Information Exchange will help with the continuity of care for those patients. Waterbury, I mentioned Staywell is up and running. Now Staywell is a little bit of an island currently out there in Waterbury. You know, hopefully at some future point we'll have St. Mary's and Waterbury Hospital connected so they can really exchange data about those patients in that community. But for the pilot, what we're going to do is basically get an independent OBGYN group called Naugatuck Valley OBGYN up with inquiry access to the Health Information Exchange so that when a Staywell OB patient is referred out just before the baby's ready to be born, you know, maybe for the last couple months of the pregnancy, then Naugatuck Valley OBGYN will be able to see all of the records for those moms-to-be that were accumulated throughout the first 6 or 7 or 8 months of patient care at Staywell. Okay, next, Ellen, please. I mentioned that eHealth Connecticut is a contractor for DSS, so there's the DSS logo over there on the right. The Health Information Exchange, we've got that globe kind of picture, which is we use to kind of designate the HIE, and then we've got providers, and we'll get into how this all works. All right, prepare yourselves for the next slide because it's a doozy. This is a pretty technical picture, but I think I can walk you all through it so that you get and gain some understanding about how it actually works. So Health Information Exchange, the whole point here is to basically connect providers that operate in different entities, be they hospitals, clinics, FQHCs, solo practitioners or small practices, nursing homes, home care, a hospice. Eventually, we hope to have connected to the exchange. But let's take an example. In the upper left, you see the blue box there, and that is a private provider entity. And we say that's a physician or a community health center, let's say. And the other blue boxes, as I say, hospitals and subacute. So, basically any private entity can choose to plug into the Health Information Exchange. So the blue is private. Then they've got their own processes, their own providers, their own technology systems. And you need, in order to play in the Health Information Exchange world, you need your own electronic medical record. Another term for that is health information technology, but basically an electronic medical record, electronic health record, where you actually collect data electronically for your patients. And if you've got that, then you can develop through standards that we've adopted, basically interface to that yellow Health Information Exchange in the middle. So the yellow part is eHealth Connecticut. And there are some technical components that make that shared service work, things like a master person index, so that Scott Cleary, coming from Hartford Hospital, can be identified as the one and only Scott Cleary, and the same as Scott M. Cleary coming from Dr. Jones' office, or Scott Miles Cleary coming from a home care agency. So by these individual entities communicating the identity of their patients, what the exchange does is reconcile identities across those different entities. And if you think about it, ultimately, if this grows into a statewide health information exchange, there will be a master index for every every resident in the state of Connecticut, ultimately 3.5 million people. And that master index will know what each of the private entities calls a given patient in terms of medical record number or other identifying attributes. So that's a very key component of the HIE. Master Provider Index also. So we know in that database, if you will, all of the providers, the doctors and the nurses and the APRNs and the physician assistants who are authorized and basically authorized to participate in the health information exchange. So every provider has an identity, and then one of the roles of the health information exchange is to be sure that that list of providers, authorized providers, is maintained, up to date, and so on. And when a provider accesses the HIE to basically access patient information, we can make sure that that is an authorized person. And then there are other kind of technical services like privacy and security, encrypting data at rest, encrypting data that flows through the communication links and so on. And this concept of a record locator service, and I'll get into that just a little bit here. So basically, we do not store clinical data, patient data, in some big old database in the middle of the universe here. Instead, we have a record locator service that knows where patient data reside. And where the data reside is in those pink hat boxes there. That's a convention to represent a database. So you see that there are multiple pink databases. Those are controlled by the individual provider, the individual providers. And what they do is provide access to eHealth Connecticut so that that information can be accessed by other authorized users wherever they may come from. So that is a very important concept. It's basically distributed information that's controlled by each of the providers but made accessible through the technology that I just described. I don't know if you're going to have any questions about the technology later on, but you now know more than about 99.9% of everybody about how health information exchange works. Okay. Ellen, next please. Okay, so my screen went blank. I got a little nervous, but here it is again. So why are we doing this? What's the benefit for the patient, for the provider who's engaged in this health information exchange? Well, basically, it's all about safety, quality of care, and efficiency. And we all that have been at this for a while, and I would say probably the industry in general, the healthcare industry in general, believes the hypothesis that, you know what, more efficient care or better quality care, safer, better quality care, actually costs less. So you get a triple whammy of value when higher quality, better safety, increased safety also costs less than an inefficient system. So that's we're basically hanging our hat on that value proposition, and what we're doing with this pilot project is to start to prove that value proposition. So improve the quality of your care, and if you think about it, as you go from, let's say, a primary care provider into an emergency room, imagine if that emergency room had immediate access to those records that exist in your primary care provider's system. So now they know at the emergency room, and maybe you've never been there before, they know your problems, your allergies, your recent medications, your recent laboratory results, your past conditions, diagnoses, procedures, you name it. I mean, just imagine the value to that provider that needs to make, immediately make patient care decisions, especially in a place like an emergency room. But even if it's not an emergency room, imagine you're leaving the hospital and moving to, let's say, a nursing home situation or a home care situation. How many times does the new provider, nurse or doctor at the nursing home or that visits you in the home says, okay, well, tell me all about you. What's your problem? What medications? Oh, you don't know what medications? Let me go looking in your drawer in your bathroom and see if I can read all the labels on all the prescription drugs. Again, imagine if that authorized provider with patient permission, very important, is able to access all that information about you, the patient, electronically by connecting eHealth Connecticut. You could just imagine the efficiency and the, seamless care that can be enabled as a result of that. And I mentioned, things like lab results, other meds that a patient might be on, allergies. Those are all very key factors in helping providers reduce medication errors. So, for example, a drug-to-drug interaction. Ooh, if I'd known you were on that drug over there, I would not have prescribed this new drug for you. Or if I knew that you were allergic to penicillin or amoxicillin or so on, I wouldn't have prescribed that to fight your infection. So, reducing medical errors, that helps with patient care, that helps with patient satisfaction, and it reduces big-time cost. Since we've got multiple providers all accessing patient data, again with patient's permission through the exchange, it's necessary that the exchange track exactly who, when, and why your medical records are being accessed. So to be able to produce that audit trail, if you will, I'd argue is a real benefit for the patient to say, hey, who's been looking at my information? And, and by the way, the patient says, I want to get that information, access to that information myself, which we intend to do in a later phase with the HIE. I think I talked about safety, and the other thing is duplication of important tests. If you just had a CAT scan yesterday in an outpatient facility, and now you show up today at an ER because you've got some whatever, chest pain, abdominal pain, and the providers at the hospital say, well, we got to get a CAT scan. Wait a minute, you don't need another CAT scan, you just had one. If they can get access to that, to the results of that CAT scan, you save time, you save money, and you're able to get on with the treatment as opposed to continued duplicate testing. Okay, Ellen, that's enough on slide 7. Now there are risks and a lot of concerns, and we've spent a lot of time, and Ellen can help describe the process we went through probably over most of a year with multiple consumer groups to see what the concerns are out there in the community about electronic health information and the exchange of it. So things like identity theft, data errors, hackers getting access to to private data. These are all certainly risks. Now we've got programs in place, technology in place, processes in place, policies in place to basically counteract each of those risks, and I can get into that a little bit later on. But yeah, there's a little bit of risk. Although, if people think that their health information is secure today, they've got that's not true. When you're dealing with paper and faxes and medical records that are left open here, there, and elsewhere, we've got issues in today's world. But nonetheless, these are very significant concerns that people have, and therefore we've addressed them head on. Ellen, please. All right, let's talk about how the exchange works. So step 1, let's assume you're going to visit your primary care doctor and you've got some issue, and that primary care doctor is going to in turn refer you to a specialist. Okay? So you visit the doctor, you sign in like you always do. Now that doctor is using an electronic health record, and basically, next slide please, Ellen. That provider asks you what's going on and collects your information. What's your problem? Maybe orders a test or a drug or two, and captures that information in Dr. Smith's electronic medical record. Now that provider and you agree that, you know what, we need a referral. Mr. Jones is the patient in this case. So we're going to do a referral. Meanwhile, that medical information contained in Dr. Smith's EMR is available to eHealth Connecticut's HIE. Next, please, Ellen. So now we've got a different doctor, Dr. Williams, and Dr. Williams is a specialist who basically inquires of eHealth Connecticut, hey, eHealth Connecticut, do you have any clinical information, any history on Mr. Jones? And eHealth Connecticut says, yes, this is the one and only Mr. Jones that you're talking about, and basically we access that information at the primary care provider's office and make that available to Dr. Williams, either through a web-based portal that Dr. Williams can actually view, or if he has the sophistication in his EMR, he can actually pull that data right into his Dr. Williams EMR. Next, please, Ellen. So here is a pretty fancy user or kind of process diagram, and I'll just quickly take you through. We won't spend a lot of time here because I think you already probably have the concept. But let's start with number one, Dr. Smith. Now, Dr. Smith has a practice management system. That's the system where the patient information is registered. The patient is registered, the patient is scheduled, and ultimately the patient gets a bill. So here is Mr. Jones registered in Dr. Smith's system, and number one shows that patient registration coming to the Health Information Exchange where the identity is confirmed, and number two is basically the Health Information Exchange now returns the fact that, yes, this is the one and only Mr. Jones, and we now have that patient registration registered in the Health Information Exchange. Step three, Dr. Smith does his thing with his EHR system, as I mentioned earlier, and actually creates a clinical document, if you want to call it a continuity of care document or a similar name, but that's the document. We call it a document, but it's actually highly structured data, again, about problems, allergies, medications, lab results, physician notes, and so on. And that document, which is stored in that database there, is now registered, number four, with the Health Information Exchange. Again, the data are not stored in the HIE, but rather the registration and location information is. And then, so basically now we've got that information available to the HIE, and if you look at number five, up on top and down at the bottom, we have role-based inquiry. So now any authorized provider can access the Health Information Exchange through that green portal and basically find the information down at the bottom there from that clinical repository. And you see in the eHealth Connecticut box some of the other databases. I already described some of those, like the Master Person Index, like the Audit Trail, and so on, the Record Locator Service or Document Registry. Next, please, Ellen. Talk a little bit about privacy and consent. As I said, with Ellen's help and AARP and probably 10 other consumer-focused agencies, whether they be healthcare focused like the AIDS Coalition, or whether it's legal folks concerned with the rights of individual residents. We went through a long process, and for the purposes of the pilot, we bottomed out on what's called an opt-in policy, which basically says that every single patient is given education about what is Health Information Exchange, who is eHealth Connecticut, and then given the choice to opt in to share medical information through the HIE, or to sign an opt-out, denial of consent form that says, no, I do not choose to participate in the HIE. So unless a patient signs that opt-in form after thorough, gaining a thorough understanding of what I just described to all of you, maybe not quite in that much detail, but unless that opt-in is provided, information is not shared. Now this is a big issue across the country, and if you talk to other health information exchanges, many have adopted this kind of conservative opt-in policy where the patient is given the choice to participate. Others have adopted an opt-out policy where basically data are shared unless the patient says, no, I don't want to, in which case that data sharing is turned off. So again, we've gone with the opt-in policy at this point. I know that the new Health Information Technology Exchange of Connecticut, the new authority, is considering whether this would be the right policy from their perspective, but this is where we are. And so each of those pilot participants that I mentioned earlier, the 3 hospitals and the 2 FQHCs, are administering this consent with real patients that come through the front door before their information is shared. Next, please. Security. I won't get into this. This gets pretty technical, but just rest assured that we have privacy and security policies that are at least the minimum required by all of the federal and the state laws that we have that protect private information, that require us to encrypt the data at rest and encrypt the data that flows through online communications. And very sophisticated role-based security, as I said, so we know every single person who is contributing data or viewing data on the HIE, and we record that in an audit log. So at any time, we can provide an individual patient or an entity with all of that transaction, audit trail. And then, one of the roles of the HIE is, of course, to watch that audit trail like a hawk to be sure that nobody is trying to gain access to patient records that they shouldn't have access to. Okay, next, please. These are some websites that you can go to. The eHealthConnecticut.org website has all this information about the Health Information Exchange, and you'll also see at the eHealth Connecticut website a lot more information about eHealth Connecticut in its role as the Regional Extension Center. And I won't get into that in any detail now, but just know that eHealth Connecticut is the statewide Regional Extension Center, basically under contract with the feds to consume about $6 million or $6.5 million of federal stimulus money to help primary care providers adopt health information technology. Remember I said that you can't participate in health information exchange if you don't have an electronic medical record in the first place. So eHealth Connecticut is also engaged to help those primary care providers, maybe 5,000 of them or so in the state, to adopt the technology so that they can in turn plug into the health information exchange. So there's everything you ever want to know about regional extension centers is also up on that eHealth Connecticut website, along with in the HIE section education materials such as you're seeing now, and a bunch of other resources for your education and entertainment. Next, Ellen, please. There are a few questions we have here. I think we have 5 or 6 questions. So, we're at kind of a funny place with the pilot because we've only got 4, soon to be 5 pilot participants live. So this, this message that says be sure to talk with your doctor about the eHealth Connecticut HIE. Well, it's premature to do that because we frankly don't know the future of this pilot that we now have up and running, and that will depend on what HITE Connecticut, the new authority, chooses to do for the statewide health information exchange. And they'll certainly consider this platform or this project and potentially other possibilities as well. So, but anyway, once we're up and running statewide, then it will be important to have these conversations with physicians because we need them in the tent, obviously, along with the patients to enable this to succeed. And then how can I participate? The administrative staff at the doctor's office or the hospital's office, the provider's office will basically have, they'll need to have been trained in all this stuff so that they can have that conversation with the patient and ultimately get that consent decision, yes or no. Next, please. We already talked about this. So a doctor, an authorized provider, can do a query by accessing eHealth Connecticut, entering patient information, and basically with with that authorized access, be able to see if information exists about that patient from other entities where that patient may have been for care. Does participating in the HIE cost me, the patient, anything? No. I mentioned that this pilot project was funded through DSS with federal grant money, And the beautiful thing about this, and this is thanks to CMS and DSS and their vision, is that this is not just for Medicaid patients. This is for any patient walking through the door at a participating HIE provider. And that's a real value in leveraging that federal and state investment for the benefit of all. It's a real strong story. Next, Alan, please. Yeah, right now we've only got those 5 participants, and hopefully we'll have, virtually every automated, well, every provider in the state, in the years to come. But it's going to take a long time for them to first adopt the technology that they need and then plug it into the health information exchange. But once we get a critical mass of participants, it's kind of like the internet way back, I don't know, 20 years ago, or it's like the person who invented the fax machine. It's like, well, here's a fax machine, and boy, it's going to be really valuable. And then the buyer says, yeah, but if I'm the only one with a fax machine, what am I going to do? Fax to myself? And we have the same kind of conundrum with health information exchange. But once you get a critical mass of folks with fax machines or internet access, then this thing takes off like a virus in a good way, for the benefit of all. And then we have a little discussion about once what do I get? What's the value for the patients? Well, in addition to the patient care and safety improvement, imagine going to a provider's office and not having to fill out that doggone form that's on that's on the clipboard that you get handed every time you show up at a physician's office. And imagine if instead of a blank form, you're provided a computer printout, and it has information not just for that provider, but all of your information that's been submitted or collected through the health information exchange. I would argue that that's a real value, even if it's just for the convenience of it for the patient or for the moms of the kids that are basically required to provide that information at every step of the way. Next, Alan, I think so that's it. There's the website again. And I think we can now, I can take a little bit of a break and a drink of water, and we can see if we have any questions.
Great. We don't have any, I urge anybody to type questions into the question pane or raise your hand if you have a question. Scott, I'm hoping you're drinking, well, I want to emphasize one thing first that you said. People should know that eHealth Connecticut doesn't have your medical records in a centralized place. That's important to say. It's more, the way you described it to me that sort of made sense to me was that it's more of a table of contents. It won't have the x-ray that I had yesterday, but it will say that Ellen Andrews has an x-ray somewhere, and it can go out and get it when an approved provider wants it. Do I have that right?
Absolutely you do, yes.
Okay. And maybe you can talk about other states, especially the states around us, because a lot of patients go to Access Care in New York or in Boston and Worcester, in Rhode Island. And where are other states around us in terms of health information exchange?
For the most part, I would say that Connecticut is a bit behind the other New England states and New York. Although New York, it depends on where you are talking in New York. They certainly do not have a big statewide system like we are, hoping to implement here in Connecticut. They've got, a different HIE program in Manhattan, a different one in the Bronx, a different one on Long Island, and so on. So what their strategy is to implement those different exchanges and then somehow connect them to each other. So if you think about it, the statewide exchange would be more a network of networks, if you will. Here in Connecticut, I think because we can and because of the vision of DSS and CMS and eHealth Connecticut, eHealth Connecticut is a statewide entity. So we tackle this problem with a statewide perspective, up front. So this thing can be rolled out on a statewide basis. And that makes it an awful lot easier because of things like the consent policy, things like the DRSA form, which is Data Use and Reciprocal Support Agreement. That's a fancy word for the single contract that every participant signs as kind of members of a health information exchange. If you look at Vermont, Vermont has a very similar model to ours with, as you say, the table of contents and the kind of the distributed data. Maine has been operational for actually a couple of years now. Maine and Vermont is opt-in, such as eHealth Connecticut is for the pilot. Maine does have a central database of all, I use that word, advisedly, but all patient data are aggregated in one physical database kind of centrally. We didn't think that that would fly, frankly, here in Connecticut, so we've got a little bit different approach, like Vermont, like Rhode Island, like Massachusetts. But anyway, Maine, it works for them, and they've got a pretty robust health information exchange operating up there. New Hampshire is probably farther behind Connecticut. Massachusetts has had a number of kind of pilot projects, pretty sophisticated ones in 3 or 4 communities around Massachusetts, but they don't have a statewide solution the way that we plan here for Connecticut. Same, Rhode Island does have a statewide vision, but I would say that they might actually, maybe they're about where we are. They've piloted some things. They've consumed some significant federal dollars for some pilot programs, but I guess the bottom line, from my perspective, is that once Height Connecticut, the new authority, really gets rolling, I think we have an opportunity in Connecticut to really leapfrog what's happening in most other parts of the country. There might be a half a dozen or a dozen very mature health information exchanges, many of which are not statewide. So again, I think we have a great opportunity here in Connecticut to really leapfrog a lot of others. That consent thing becomes tricky because let's say you've got snowbirds from Connecticut that zip down to Florida in the winter, especially winters like this one. Well, if eHealth Connecticut has a strict opt-in policy, or vice versa, if Connecticut adopts an opt-out policy, but Florida has an opt-in policy, and they're different, it becomes tricky to reconcile those across state lines. And the feds are working an awful lot to try to help with some of those solutions, but frankly, I don't know that there's a real great one out there. So we'll cross that bridge when we come to it. The thing we need to do is get everybody in the state of Connecticut connected to the health information exchange, and then we can be flexible in how we interact with folks across state borders.
Great. We have 2 questions so far. Drew Hamilton asked, with the health reform bill beginning in 2014, an exchange will be established in each state to help consumers make valid this is the insurance exchange I think he's talking about.
Yes.
To help consumers make valid comparisons between health insurance plans and purchase insurance. Will the insurance requirements be integrated as a module into this same HIE structure you covered today, and how are the requirements being defined?
Yeah, I would say the insurance purchasing exchange is really totally separate from this. We're talking about patient care with this health information exchange that is, exchanging real sensitive private patient data. The insurance purchasing exchange will be a resource or a way for individuals or maybe small groups to go online and see what insurance options might exist and to actually buy insurance through some sort of an online process. Maybe we could trade links or something so people could learn about health information exchange kind of while they're over there buying their insurance, and maybe there's some synergy, but fundamentally it's a totally separate program. Right.
I do know that my students and policymakers are very confused about the difference between a health information exchange and an insurance exchange. We should probably think about that when we're naming them. Marlene Kerbin asks, can you talk about the required qualifications for EHR vendors? Are they certified?
Well, there's a whole program that the feds have been behind, and also now that the state Medicaid, DSS, the state Medicaid agencies are also involved, and even some private payers are starting to hop on the bandwagon. But there's this whole concept of, quote, meaningful use of a certified electronic health record system. And what the feds and the state is saying to providers, hey, if you achieve these 25 meaningful use objectives. Actually, there are 15 core, and then you choose 5 of an additional 10. But if you achieve these meaningful use objectives, then there is incentive money that will flow to you, the individual provider, over a period of time. In the case of Medicare, it's about a $43,000 number per provider. I think that's about right. If it's Medicaid, the number is, I think, $63,500. And a provider can either choose to go after Medicare if they've got Medicare patients, or if they've got enough Medicaid patients, they can go after that incentive, not both. So that's the incentive money, and to get that incentive money, you have to achieve meaningful use, as I described, and to achieve meaningful use, you have to have installed a certified electronic health record system. And there are, I don't know what the number is, 50 or maybe 100 now, systems that the feds have certified. So if you select and implement one of those systems and then get to meaningful use, that's a good thing. And one of the 3 or 4 of the meaningful use criteria are related to health information exchange. So that's one of the things we're doing as the Regional Extension Center, which is fundamentally all about helping providers get to meaningful use. We're saying, hey, if you plug into eHealth Connecticut, you can tick off those meaningful use objectives right away. So Stay Well, Hartford Hospital, Lawrence Memorial, St. Francis, they've already done those few kind of meaningful use criteria that are required for what's called Stage 1, 2011 meaningful use. So that's a complicated answer probably, but hopefully that helped a little bit.
Well, I think that's it for questions. If somebody has another, could they type it in or raise their hand? But as we're wrapping up, maybe you could talk for a minute about all that confusion. It is extremely confusing and time-consuming for providers to implement an EHR in their practice. But eHealth, and you talked about this a little bit, but maybe give it another couple of minutes to talk about how eHealth has federal funding to help them with that, and how can they access that help?
Yes, all the answers to those questions are on the website, ehealthconnecticut.org, but you're right. eHealth Connecticut is an awardee for a 4-year contract with the Office of National Coordinator of Health Information Technology. That's the group, that's the feds, division of HHS, but that's the feds, and $6.5 million of money is available for us, eHealth Connecticut, to appropriately spend in. We're coming to the end of year 1, although we didn't get started until later in year 1. But over the next 3 years, that money is to be used to help as a subsidy, basically. Sorry about that. As a subsidy to help what they call priority primary care providers select, implement, and get the meaningful use of electronic health records. So eHealth Connecticut has a number of subcontractors that are deployed to help provider customers just with this challenge of selecting a system and then implementing it and getting to meaningful use. The stimulus money, the subsidy from the feds, is only to be used for priority primary care providers, which basically are primary care providers in small practices. But eHealth Connecticut also would like to provide support to any provider who wants to go on that journey. eHealth Connecticut would charge market rates, consulting rates, if you will, to help folks that are not qualified as priority primary care providers. But that's the idea, is to provide a resource to help folks actually move forward with that implementation.
Well, great. It looks like we've answered everybody's questions. So I want to thank you, Scott, very much for explaining this and making it more understandable. I'm sure there's still lots of questions, but Scott has his contact information there. And a video of this webinar will be posted online just as soon as I get around to it. And I want to thank everybody for joining us today. Thanks a lot.
My pleasure, Ellen, and thanks everybody for listening in. Call me anytime.
Great.
Thank you.